All right, Professor. I'm looking at the calendar, and I'm looking at this stack of books on my desk. I've got Miller, I've got Morgan, and right on top, looking very intimidating, is Kaushik Jothanath.
Ah, the exam prep library.
And honestly, I have a knot in my stomach. The Gujarat University MD anesthesiology exams are looming, and every time I look at the obstetric anesthesia section, I feel like I'm walking into a minefield.
Yeah.
Specifically, the emergencies. It feels like there is zero margin for error.
That feeling, that is actually a good sign. In obstetrics, appropriate anxiety keeps you and your patient safe. You are managing two lives simultaneously, and the physiology is, completely different from your standard surgical patient.
Things go south so fast.
Very, very quickly. But for the exam, panic is your enemy. Structure is your friend. Today, we are not just chatting. We are doing a focused drill.
That's exactly what I need. No fluff, just the hard-hitting facts I need to verbalize when the examiner is staring me down.
Exactly. We're going to simulate the preparation for those high-stakes scenarios. We're going to tackle two specific, often linked emergencies: manual removal of placenta, or MRP, and the one that scares everyone, uterine inversion.
Right.
You might see these as a short note, or more likely as part of a major 20-mark long answer question on obstetric hemorrhage. If you look at the DNB topic list, question 11 specifically references retained placenta. So put your student hat on. I'm the external examiner today.
Okay.
Let's see if we can get you from a pass to a distinction.
I'm ready. Let's start with Part A, manual removal of placenta.
Yeah.
If I'm sitting in the Viva and you ask me to define it, I can't just say the placenta didn't come out. I need the precise textbook definition.
Correct. Accuracy matters. So how do you define retained placenta for the purpose of the exam?
Okay, strictly speaking, retained placenta is defined as the failure of the placenta to be expelled within 30 minutes after the delivery of the baby.
That is the correct answer. Now, you will read some older texts or perhaps some obstetric guidelines that mention 60 minutes. But for your exam and for active management of the third stage of labor, 30 minutes is the critical threshold.
Right, 30 minutes.
Why do we care so much about that timestamp? Why not just wait an hour?
Because as long as it's in there, the uterus can't do its job. It stops the uterus from contracting down properly.
Exactly. The uterus is a muscle that needs to shrink to stop bleeding. A retained placenta prevents the efficient shearing of the placental bed. It complicates about, 2% of all deliveries worldwide?
That doesn't sound like a lot, but I guess when you think about the total number of deliveries.
It becomes a huge number, and it is a leading cause of primary postpartum hemorrhage, or PPH. And even if they don't bleed immediately, if you leave tissue behind, you're setting them up for secondary PPH days later, or, severe sepsis.
So it's a bread and butter emergency.
It is. Now, physiologically, why does the placenta stay inside? What are the mechanisms?
I've categorized this into three main buckets in my notes. The first, and I think the most common, is uterine atony.
Right. The engine just stops. The retroplacental myometrium fails to contract. If it doesn't contract, the surface area doesn't shrink and the placenta doesn't shear off. That's the most common and usually the easiest to treat pharmacologically. What's number two?
The second one is a trapped placenta.
Explain that.
This is where the placenta has actually separated from the wall, but the door has slammed shut, the cervix closes up, a constriction ring forms before it can get out.
Exactly. That distinction is vital for us as anesthetists because the management is diametrically opposite. If it's atony, we want contraction. If it's trapped, we might need relaxation.
A very important point.
But what is the third cause, the one that makes every anesthetist and every obstetrician sweat?
Abnormal placentation.
The accreta spectrum.
This is very high yield. If you get a question on MRP, you cannot ignore accreta. You need to be able to rattle off the histology from Kaushik Jothanath or Yao and Artuzio. Give me the breakdown of the spectrum. Okay, let me try to get the percentages right. So placenta accreta is the most common of the bad bunch, about 75 to 78% of these adherent cases.
And what is it?
That's where the chorionic villi attach directly to the myometrium because the decidual basalis is absent.
Good. No decidua means no safety layer, no easy peel surface. Next.
Next is placenta increta. That's about 17%. The villi invade into the myometrium itself.
And the nightmare scenario.
Placenta percreta, about 5 to 7%. The villi go right through the myometrium, through the serosa, and potentially invade into the bladder or the bowel.
Excellent. In the exam, if you are discussing MRP, you must mention that if the placenta is not coming out, it might be an undiagnosed accreta. And here's the clinical pearl. If you pull on an accreta, you do not get the placenta.
You get a disaster.
You trigger massive life-threatening hemorrhage.
It effectively becomes a surgical emergency at that point.
Instantly.
So let's talk about the clinical features leading up to our involvement. Obviously, the placenta isn't out. There's usually vaginal bleeding, though I suppose it could be concealed if the placenta is plugging the os like a cork.
Correct. And you need to look for signs of hemodynamic instability. Remember, young, healthy, pregnant women compensate incredibly well. They maintain their blood pressure by clamping down their peripheral vessels.
So you see tachycardia first.
Tachycardia often precedes hypotension by quite a bit. Also, on abdominal palpation, the uterus might remain discoid, flat, and round. If it had separated, it would usually become globular.
Right.
But let's get to the core of the exam question, the part they really want you to answer. The anesthetic considerations for MRP. You are called to the labor room. What is your primary safety concern?
The airway. It'd have to be the airway.
Always.
Full stomach risk.
Never, ever forget this. It doesn't matter if she hasn't eaten in 12 hours. It doesn't matter if she only had ice chips. From the second trimester onwards, specifically after roughly 18 to 20 weeks, every pregnant woman is a full stomach risk.
Why? It's hormonal and mechanical. Progesterone relaxes the lower esophageal sphincter, and the gravid uterus physically displaces the stomach and changes the angle of the gastroesophageal junction.
Spot on. If you are inducing general anesthesia, you treat it as a full stomach, period. You do not gamble with aspiration and obstetrics.
And then there's the blood loss,
Which is notoriously underestimated. Morgan reminds us that hemoglobin levels above 9 grams per deciliter are usual in pregnancy. But in these emergencies, we often tolerate lower. However, anything below 7 is a red flag safety threshold.
You have to assess the volume status right away.
Immediately. Is she shocked? Is she just anxious? And remember, MRP is an intensely painful procedure. You cannot just give a little sedation and hope for the best.
Which leads us directly to the choice of anesthesia. This is the very high-heeled section where I feel like a lot of candidates trip up regarding regional versus general.
It's a critical decision point.
So if the patient is hemodynamically stable, what's my go-to?
If she has a working labor epidural in place, that is the gold standard. You use what you have, you top it up.
What drugs are we using for the top-up? We're in a hurry here.
We need speed and density. Lidocaine 2% with adrenaline is the classic choice. Adrenaline limits systemic absorption and, improves the quality of the block. Or chloroprocaine 3% if you have it. It's extremely rapid onset, metabolized by plasmacholinesterase, so it's safe.
Even though the baby is out.
Even though the baby is out. The point is, you need a dense block rapidly because the obstetrician is going to be introducing their hand high into the uterine cavity.
What sensory level are we aiming for?
Since it's uterine manipulation, T10 covers the uterine pain. However, because they are exploring, you often want it a bit solid, maybe a little higher, but T10 is the absolute minimum requirement. Now, what if she doesn't have an epidural, but she's stable?
Then we're looking at spinal anesthesia. A subarachnoid block?
Yes. It avoids airway manipulation, which is a huge plus given the difficult airway risk in pregnancy. But what is the specific risk of a spinal in a bleeding obstetric patient? This is the physiology question that separates the pass from the fail.
Sympathectomy. If she's hypovolemic and I knock out her sympathetic tone with a spinal, her blood pressure will crash.
Exactly. Remember what I said about compensation. She's maintaining her pressure by intense vasoconstriction. A spinal releases that constriction. You can turn a compensated hemorrhage into a cardiac arrest in seconds.
So you have to be really sure about her volume status.
You must be confident. Kaushik Jothanath mentions a saddle block as an option for dilation and curettage. But generally, for a full manual removal where they need to reach the fundus, a standard spinal is preferred to ensure that T10 coverage. But you have to preload or co-load with fluids aggressively.
Okay, but let's say the situation is worse. She's bleeding heavily, she's tachycardic, maybe a bit hypotensive, or the obstetrician says, I can't wait for a spinal to set up, she's bleeding out.
Then you're in general anesthesia territory. Indications for GA are hemodynamic instability, coagulopathy, because you can't put a needle in the back if her platelets are low, or her clotting is off failed regional, or, of course, patient refusal.
And the technique. It's not a standard induction, is it?
Strictly RSI. Rapid sequence induction with cricoid pressure. Mandatory. No debate.
Now, induction agents. This is a potential Viva trap. She's shocked. What do you use?
If you reach for propofol, you might kill her.
Because of the vasodilation and myocardial depression.
Correct. In a shocked patient, propofol causes profound hypotension. Kaushik recommends ketamine, 1 to 2 milligrams per kilogram. Why ketamine?
It's a sympathomimetic. It increases heart rate and blood pressure, or at least supports it, by preventing the reuptake of catecholamines.
Precisely. It supports the hemodynamics. Etomidate at 0.3 milligrams per kilogram is your other stable option. But ketamine also provides excellent analgesia.
What about maintenance? This is where it gets nuanced, right? Because we need the uterus to behave in specific ways.
This is where the art of anesthesia comes in. If the placenta is trapped by a constriction ring, that trapped placenta scenario we discussed, you need uterine relaxation to get the hand past the ring.
So you need to soften the uterus.
Exactly. And volatile agents, sevoflurane, isoflurane, are excellent uterine relaxants. So you might run the gas a little higher initially to relax that ring.
But there's a catch.
A big catch. Volatiles cause uterine atony. They stop the uterus from contracting. So once the placenta is out, what must you do?
I have to dial it down immediately.
You must shut it off or go to very low concentrations, like below 0.5 MSC. Once the placenta is out, you want that uterus to clamp down like a vice to stop the bleeding from the placental bed.
So you switch tactics completely.
You switch to low-dose gas or just nitrous oxide, opioids, and maybe a propofol infusion, and you immediately start your uterotonics.
Speaking of uterotonics, let's run through the protocol. This is checklist territory. We've got the placenta out. What do I give?
Timing is key. You give these after the placenta is removed. If you give them before, you might trap the placenta further. First line, oxytocin. 5V infusion or a slow bolus. Why slow?
A rapid bolus of oxytocin causes direct vascular relaxation, hypotension, and reflex tachycardia. The last thing a bleeding patient needs.
Correct. Usually 3 to 5 units slow IV, then start an infusion. If that's not enough, we go to second line, methyl 0.2 milligram IM. What is the absolute contraindication?
Hypertension or preeclampsia. It causes intense vasoconstriction.
Correct. If she's preeclamptic, you skip Methergine. Third line, Carboprost, also known as PGF2 alpha, 0.25 milligram IM, contraindication.
Asthma. It causes bronchospasm.
And finally, Misoprostol. It's a prostaglandin E1 analog. You can give it rectally or sublingually. Very effective, keeps the tone up, and has a good safety profile.
Okay, so that's MRP. It seems straightforward unless it turns out to be an accreta.
And that is the critical safety stop. If it is an accreta, meaning the obstetrician puts their hand in and cannot find a plane of separation, they must stop.
They can't just fair force it.
If they say, I can't find the edge, and they pull, the patient will bleed to death on the table. That converts to a surgical management, likely hysterectomy, and you activate the massive transfusion protocol immediately.
Understood. That covers MRP. Now, let's move to the second scenario, the one that keeps residents up at night. Uterine inversion.
This is a true obstetric emergency. It's rare, thank goodness, but the mortality is high if it is missed or mismanaged.
Let's get the definition right for the exam.
Uterine inversion is the turning inside out of the uterus, where the fundus prolapses through the cervix. It's like turning a sock inside out. It can be acute, subacute, or chronic. But for us, for the emergency call, we are concerned with acute inversion happening right there in the third stage of labor.
What actually causes it? I've heard pulling too hard is the main culprit.
Usually, yes. Mismanagement of the third stage, traction on the umbilical cord when the uterus is atonic, or doing the Crede maneuver pushing on the fundus when it's not contracted, basically pushing or pulling on a relaxed uterus.
Now, the pathophysiology here is unique.
Yeah.
In the exam, they always ask about the type of shock, and this is where people get confused.
This is the very high yield point for Part B. You will see a patient who is shocked out of proportion to the visible blood loss. She might have only lost 200 milliliters of blood, but her blood pressure is 60/40. Why?
It's the neurogenic component.
Exactly. Think about the anatomy. The inversion puts massive stretching traction on the ovaries, the peritoneum, and the broad ligaments. This triggers a profound parasympathetic response. It is a vagal reflex.
The huge vagal response.
So you get bradycardia and hypotension. It is a neurogenic shock mixed with hemorrhagic shock.
That's a crucial distinction, because if I only treat it as bleeding, I'm missing half the problem.
Precisely. You will be pouring fluids in, but the patient remains hypertensive because of that intense vagal tone. You have to fix the anatomy to fix the physiology.
So clinical features.
The classic triad. 1, a visible or palpable mass at the introitus. It looks bluish-gray, almost like a tumor. 2, a non-palpable fundus on abdominal exam. You feel for the uterus, and it's just not there.
It's missing.
It's missing. 3, hypotension and collapse and pain, severe tearing pain.
Okay, let's look at anesthetic priorities in uterine inversion. This is marked as absolutely essential in our outline.
Yeah.
What is the golden rule here?
The simultaneous rule. In most of medicine, we say ABC, airway, breathing, circulation, before we treat the specific pathology. Here, it's different.
It is.
You cannot wait to resuscitate before you reposition the uterus. And you cannot wait to reposition until you've resuscitated. They must happen at the same time.
Why? Why is it so urgent?
Because the longer the uterus is inverted, the more edematous and congested it becomes. A constriction ring forms around the inverted part. If you wait, you will never get it back in. And as long as it is out, the patient stays in shock.
Okay, so immediate actions. What's the drill?
Call for help. This is an all-hands-on-deck situation. 100% oxygen. 2 large-bore IVs, 14 or 16 gauge. Aggressive fluids. And this is crucial. Discontinue any oxytocin immediately.
Because we don't want the uterus to contract while it's inside out.
Exactly. If it contracts while inverted, it becomes a hard, tight ball that you cannot push back through the cervix. You need it flaccid.
And that leads us to the role of anesthesia in uterine reposition. The obstetrician is trying to do Johnson's maneuver, pushing the fundus back up through the cervix. They need us to relax the uterus.
Correct. We need profound uterine relaxation. This is the pharmacologic cornerstone of the exam answer. What drugs do we use?
The books, Kaushik and Miller, both highlight nitroglycerin.
Yes. 5-E nitroglycerin, or NTG, it is a potent, smooth muscle relaxant.
What's the dose?
You are giving boluses of 50 to 100 micrograms. You can run an infusion, but in the acute setting, you want immediate effect. You give the bolus, wait 45 to 90 seconds, and the uterus turns into jelly.
But it's a vasodilator, so you have to be ready for the blood pressure to drop.
Be ready for hypotension, yes, but you need that relaxation.
Are there alternatives if I don't have NTG drawn up?
Terbutaline, a beta-2 agonist, 0.25 milligrams subcutaneously, or IV, or magnesium sulfate. But NTG is generally preferred because it's very short-acting. Once you stop it, the effect wears off quickly, which is exactly what we want.
Okay, what about the anesthetic technique, regional or general?
In a true acute inversion with shock, general anesthesia is the preferred route.
Why is GA preferred here when we usually try to avoid it in obstetrics?
2 reasons. 1, airway control. The patient is shocked, likely has a full stomach, and is often vomiting from the pain and the vagal response. You need an RSI to protect the lungs. 2, you get access to volatile anesthetics.
Halogenated agents.
Yes. Sevoflurane or isoflurane are the most potent uterine relaxants we have, better than NTG in some hands. You might need to crank the sevoflurane up to 2 MAC really deep transiently. This relaxes the uterus completely, allowing the obstetrician to push it back.
And regional.
Usually contraindicated in acute inversion. The patient is in severe hypovolemic and neurogenic shock. Doing a spinal is dangerous. Plus, it takes time. You don't have time. The only exception is if she already had a working epidural and she isn't profoundly unstable, but that is rare in this scenario.
Okay, so visualize this. We've induced GA, we've given NTG or high-dose volatiles, the uterus is soft, the obstetrician pushes the uterus back in. Success. Now what?
Now we do the U-turn. The strategy flips 180 degrees instantly. The moment the fundus is repositioned, you have to reverse everything you just did.
So stop the relaxants.
Immediately. Turn off the volatile agent, wash it out with high flows of oxygen, stop the NTG infusion, and you immediately start the contractants.
Resume oxytocin.
Yes, high dose. Start the ergometrine if there's no hypertension. Start the Carboprost. You need the uterus to firm up immediately. If it stays relaxed, it will just invert again the moment the obstetrician lets go.
And it will bleed.
Massively. So it's relax to replace, then contract to retain.
That's a great summary.
And the obstetrician usually holds their hand inside, performing bimanual compression until they feel the uterus firm up around their fist.
Okay, let's move to part C, comparison and exam integration. This is for those compare and contrast questions that the examiners love.
Right, so I'm the examiner. Summarize for me the key differences in tone management between MRP and uterine inversion.
Okay, so for MRP, we generally want the uterus contracted to prevent bleeding. Unless the placenta is trapped by a constriction ring, then we need a little relaxation.
Okay, and for inversion?
For inversion, it's totally different. We need total paralysis of the uterus, first mandatory relaxation, then maximum contraction.
Perfect. And hemodynamics?
MRP is primarily hemorrhagic shock. Inversion is neurogenic plus hemorrhagic shock.
And what's the key sign of that neurogenic component?
The bradycardia and the disproportionate hypotension, the shock that just doesn't match the blood on the floor.
Excellent. Let's talk about complications and post-op care. What am I watching for in the ICU?
Well, infection is a big one. You've had hands inside the uterus, essentially introducing bacteria into a raw bed. Sepsis is a real risk.
So antibiotics are mandatory.
Yes. And what about renal issues?
Acute renal failure is a risk from the hypovolemia and shock. You need to monitor urine output closely. And rarely, but historically significant, is Sheehan syndrome.
As pituitary necrosis, right?
Yes. The pituitary gland enlarges during pregnancy and is very sensitive to ischemia. Prolonged hypotension can cause necrosis of the anterior pituitary. If the patient can't breastfeed later or remains amenorrheic, think Sheehan's.
Now, the Viva traps. These are the moments where the examiner looks at you over their glasses and tries to lead you down the wrong path.
Trap number 1, the oxytocin trap. The examiner says, Dr. Candidate, the patient has an inverted uterus and is hypotensive. She is bleeding. Do you start oxytocin to stop the bleeding?
So tempting to say yes to stop the bleeding.
And if you say yes, you fail. You must firmly say, no, sir. Starting oxytocin before repositioning will constrict the cervical ring and make replacement impossible. I will only start it after the uterus is successfully repositioned.
It takes confidence.
It does, but it shows you understand the mechanics. Trap number 2, underestimating the shock.
Right, just treating the bleeding?
Yes. If you treat inversion with just fluids and pressors, and you ignore the need to stop the traction, which you do by repositioning, the patient will continue to spiral due to the vagal reflex. The cure for the shock is repositioning the uterus.
And for Creta, the trap there.
The trap is trying to remove it. If you are describing an MRP and you suspect a Creta, the safe answer is, I will advise the obstetrician to stop manipulation and prepare for surgical management, likely a hysterectomy. Never say you will pull harder or try to dissect it off manually.
That is a death sentence. Okay, diagrams. For a written exam in Gujarat University, or anywhere really, we need to draw. What am I drawing?
Visuals get you marks. For inversion, draw the mechanism.
Yeah.
Show the fundus passing through the cervix. It's a simple schematic, but more importantly, draw the management algorithm.
Okay, walk me through the boxes.
Get a pen. Box 1, diagnosis and call help. An arrow leads to box 2, stop oxytocin and start fluids. Then another arrow to box 3, attempt manual replacement.
What if that fails?
Then an arrow from box 3 points to box 4. If fails, give uterine relaxant. And in parentheses, put NTG or GA with volatiles.
Enough for there.
Arrow to box 5, replace uterus. And the final critical step, box 6, stop relaxant and give uterotonics. If you draw that flowchart, you've basically passed the question before they even read your text.
That is incredibly helpful. It structures the answer visually. Let's wrap up with the take-home bullet points, the summary for the exam conclusion.
Okay, pencils up. Here is your summary for the 20-mark answer.
MRP is for retained placenta, which is defined as greater than 30 mins post-delivery. The causes are atony, trapped, or Creta.
All obstetric emergencies are full stomach risks. RSI is mandatory for GA.
Always.
3. Uterine inversion is a neurogenic shock event. Look for bradycardia and hypotension out of proportion to blood loss.
The anesthetic goal in inversion is relaxation, then contraction. Nitroglycerin and volatiles are your best tools.
Never pull on a confirmed Creta.
Anesthesia in obstetrics is not just about keeping the patient asleep. It is about actively manipulating uterine tone to save the mother's life.
That feels manageable. It takes the panning out of it when you have a step-by-step plan.
Exactly. The examiners at Gujarat University, or anywhere, really aren't looking for you to be a wizard. They are looking for you to be safe. They want to know that you understand the physiology, that you won't give a spinal to a hypovolemic patient without thinking, and that you know when to use nitroglycerin.
It's about showing you grasp the mechanism.
If you show them you understand the mechanism, the neurogenic shock, cervical ring, you separate yourself from the average candidate.
Professor, thank you. I'm going to go practice drawing that algorithm and verbally rehearsing the simultaneous resuscitation explanation for the Viva. It really is all about the phrasing.
Good plan. Try it out. Speak it out. You'll do fine.
And to our listener, thanks for joining this deep dive. Hopefully this helps you prep for your next shift or your next exam. Remember, in these emergencies, structure saves lives. Keep learning.
And stay safe.